Okay. Now it's better?
Yes.
Okay, so I repeat, or the
Yeah,
biodata was clear and the chief
just
complaint.
start over because I forgot to press record. Sorry.
Okay. As I mentioned, our patient today is JNM. He's 37-year-old male from Tarakaniti, married with 5 children. He's a farmer, and he was admitted 3 weeks ago through accidents and emergency. His chief complaints were 2-day history of vomiting of blood, 2 months history of abdominal distension. Our patient is known to have upper GI bleed, and he is on medications he does not know, and reports that he is compliant with them and is in follow-up at Kenyatta National Hospital Clinic. Patient was relatively well 2 days prior to admission when he reports to have developed sudden onset of vomiting blood, 3 in total, 2 episodes on day 1 and 1 episode on day 2. The vomitus was of coffee ground appearance mixed with ingested food. It was filling 1 small cup full, approximately 100 ml per episode. The vomiting was triggered by meals occurring a few minutes after eating. Patients reports associated epigastric discomfort of burning nature, passage of black tarry stool with offensive smell, heartburn, bloating, indigestion, and loss of appetite. However, he reports no associated hematophysia. He also reports to have episodes of dizziness, headaches, rapid regular palpitation, easy fatigability, and occasional shortness of breath. He denies losing of consciousness at any point. Patient also complained of 2 months history of generalized abdominal distension. The generalized abdominal distension was of gradual onset that was progressively worsening and associated with epigastric pain of burning character, abdominal discomfort, yellowness of eyes, and pruritus. There were no exacerbating or relieving factors. The patient reports that this complaint has affected his activities of daily living, such as walking for a few distance, brushing his teeth, changing of clothes, his farming activities. He denies history of passing pale stool, dark urine, or lower limb swelling. He also denies history of hotness of the body, significant weight loss, night sweats, or dysphagia. He also denies history of bleeding from gums, epistaxis, easy breathability, or hemoptysis. He reports that he had previous ulcers and he was treated for. That was September 2020 when he presented with these symptoms. He denies history of smoking or alcohol consumption. Since he's from Tarakaniti, he reports that he has not been in any contact with a large water body. There's no history of similar presentation in first-degree relatives. There's no history of recent NSAID, aspirin, corticosteroids, or oral anticoagulant use. There's no history of hepatitis B or C vaccination. However, there is history of multiple blood transfusions for similar presentation. There's no history of multiple sexual partners, and he also denies history of IV drug use. On the intervention, this is his 4th admission following a similar presentation. First admission was at Muranga Hospital in February 2020. Second admission was at Nkubu Hospital to September 2020. Third admission was at Embu Hospital, February 2022. He has received blood transfusion in all previous admissions. The patient can't recall how many pints of blood he has received. He reports that he had an OGD done in September 2020, and this was purely diagnostic. And he told me that the doctors told him that the The OGD revealed a grade 4 esophageal varices. There were also presence of gastric varices. There was also duodenal ulcers, and there was moderate erosive gastritis. Once I questioned him further if there was any therapeutic intervention through the OGD, but he said he was not. The doctors did not clearly told him. On the past medical history, as I mentioned in my intervention, this is his fourth admission. There is history of receiving multiple blood transfusion. There is no previous surgery. There is no history of chronic illnesses. Patient denies any or is not known to have any food or drug allergies, and he is seronegative. The family history, this is the fourth born of 5 siblings. His mother is alive and well. Father deceased due to an unknown illness. There's no family history of chronic illnesses. He's married to 1 wife and is a father to 5 children, 3 boys and 2 girls who are all alive and well. In the social history, the patient is financially unstable. This is why, as he told me that he could not even afford the OGD, and it actually took him a while to perform an OGD because he's financially constrained. He also told me that he has an active NHIF. He resides in 1-bedroom house in Tharakanithi, which is well ventilated and is made of bricks. He boils water for drinking and cooks with water from the well. He uses pit latrine and burns litter outside their homestead. The patient does not keep any dogs or cat or any pet. In the review of system, apart from genitourinary system and cutaneous, the rest were unremarkable. For the genitourinary system, the patient complained of frequency of urination, and I asked him if he is on any medication, and he told me he's on Lasix. That's the pharmacological name is furosemide, and I attributed the frequency of urination to the Lasix is on. For the cutaneous, as I observed his skin, it was dry and it was coarse as well. In summary, I'm presenting JNM, that 7-year-old male from Tharakanithi with 2-day history of hematemesis, 2-month history of generalized abdominal distension associated with melena, epigastric discomfort and pain, yellowness of eyes, dizziness, palpitations and headaches. This is his 4th admission following similar presentation. On general examination, I observed a young man in fair gentle condition, lying supine, IV cannula in situ in the left cubital fossa, not in obvious respiratory distress, in a good nutritional status, oriented in time, place, and person. On the vital signs, the pulse rate was of 90 beats per minute. It was regular and of normal volume. The respiratory rate was 22 breaths per minute. He was tachypnic. The blood pressure, he was normotensive, 100 of systolic and 54 of diastolic. Normal temperature of 37.6 degrees Celsius. There was presence of jaundice and pallor, cyanosis, lymphadenopathy, edema, wasting, or dehydration were absent. Per abdominal examination, on general observance, there was palmar, conjunctival, and lingual pallor. So this was extensive. And from this, I could note that this patient, he was severely anemic. There was scleral jaundice that was present. Cup refill was less than 3 seconds, so it was 1 second. I observed normal nails with no evidence of peripheral cyanosis or clubbing. There were no signs of peripheral stigmata of liver disease, such as palmar erythema and Dupuytren's contracture. There were no lymphadenopathy observed. On inspecting the abdomen, it was symmetrically distended with flank fullness. It was moving with respiration. The umbilicus was everted. There were no prominent superficial distended veins, but there was presence of excoriation scars. all over the abdomen. On superficial palpation, there was no tenderness that was elicited. There was palpable mass of the left upper quadrant. On deep palpation, the mass found to be enlarged spleen growing infero-medially. It was palpable 16 centimeters below the costal margin. On percutting the abdomen, the liver span was 12 centimeters. There was fluid trill and shifting dullness. On auscultating, there was normal bowel sounds present. On inspecting the precordium, it was normoactive with no surgical present, no surgical scars present. On palpation, the apex bit was palpable in the 5th intercostal space, mid-clavicular line. No heaves or thrills were palpable. On auscultating, S1 and S2 were heard. There were no murmurs. The respiratory system, the chest was symmetrical. It was symmetrical chest movement. Trachea was central. There was normal vocal perimeters. Symmetrical chest expansion, equal bilateral air entry, vesicular breath sounds were present, and there was also normal vocal resonance. Central nervous system examination, Glasgow Coma scale of 15 out of 15, motor and sensory intact, CNS was all intact. So what was my impression? One thing that stood out to me was this was a case of upper GI bleed, and I mainly attributed it to secondary to esophageal varices. And on reviewing further, the esophageal varices could mainly be secondary to portal hypertension. I'm not sure, but overall, I thought this was a case of chronic liver disease, but it's not yet established. But as we go on reviewing the case, we will, the doctor will tell us more about it. So the management was, they perform an urgent OGD. As I mentioned, the patient was financially unstable, and it took him almost a week to perform an OGD, of which even after checking for the results of the OGD, I was unable to access it. For the baseline investigations, they did a full blood count. They did UECs and LFTs. They also performed a coagulation profile, a lipid profile, antinuclear antibodies, triple serology, tumor markers. Since our patient was severely anemic, he was being prepared for blood transfusion, so they did grouping and cross-matching. So the results were, for the full blood count, the WBCs, there was leukocytopenia. It was really low, 0.73. RBCs were also low, platelets were also low, HB was severely low. So the comment was this was a case of pancytopenia. For the UECs, sodium was normal, potassium was normal, chloride, the chloride was high, was elevated, urea and creatinine were normal. For the LFTs, AST was elevated, ALT was normal, gamma GT was normal, total bilirubin and ALP were normal. For the tumor markers, there was all of the tumor markers that were sent, that were being investigated, such as CA, alpha fetoprotein, CA125, CA19, all of them were absent. Also, antinuclear antibodies were also absent. The lipid profile was normal. There was deranged coagulation profile with increased bleeding time. There was normal APTT, PT, and TT were all normal. Thank you. I think I'm done with the case. I welcome any question or comments.
Thank you for the presentation, well done. And anyone with a question, clarification before we proceed to the presentation on upper GI bleed? Okay, so there is a question from Rukia, why OGD was indicated. I'm hoping Najma will be able to answer that question when she's doing her presentation, next presentation. So Rukia, that will be answered in the presentation. Okay, if there are no comments, I think the history was adequate, well presented. And maybe a few additional information that will have been important to get was, since admission, what has been done for the patient? Because I think it's a mixed group. Possibly, I'm assuming they're 40 years here. So in your HPI, other than probing the presenting symptoms, looking at the associated factors so that you can either rule in or rule out diagnosis. And then the next component is look for complications. And then the last component is usually what has been done for the patient since admission. So OGD was done. That only got mentioned towards the end, that OGD was done. You couldn't find the report, but what has been done for the patient? Has he been transfused? And what is his current status? For all your long case presentations, your HPI, if the patient has stayed in the ward for some time, then that should appear, that what has been done for the patient and how is the patient at that time. Okay?
Yes, Dr.
Okay. And Najma, what do you think about your diagnostic formulation? You have upper GI bleed secondary to variceal bleeding that you think is secondary to portal hypertension. For now, it's still unclear. It's difficult to say chronic liver disease. There are no stigmata of chronic liver disease. So we still don't know what's the cause of the portal hypertension. And what else should appear as part of your diagnostic formulation, both from your history initial presentation and also the OGD that was done in 2020 that you had the benefit of having the findings of the OGD. Anyone, doesn't have to be Najma. Just go back to your initial, I think, third or fourth slide in your HPI.
The point on ulcers, the duodenal ulcers.
So there's duodenal ulcers, there's erosive esophagitis, and then in your presenting complaints, other than hematemesis, what else was there? Just the text is too minute.
There was melanoma.
Mm-hmm. So you had epigastric pain,
Yes.
you had heartburn, and what else have you had? For patients who have just portal hypertension will present with hematemesis. Majority of them, unless there is portal hypertension gastropathy, and that's when you have now erosive esophagitis. If someone didn't hear the history of the previous bleeding with the OGD done and the findings of the OGD, the initial differential will be a bleeding peptic ulcer disease from your presentation. And you can have that even portal hypertension. You can get portal hypertension gastropathy. Okay. So there seems to be no question. I think we can proceed to the presentation.
Okay. So at the end of this presentation, I would love each and every one of you to define an upper GI bleed enumerate the causes of upper GI bleed. You describe the symptoms and signs or clinical features. What are the investigation or diagnostic workup? Since this is a serious syndrome or serious, can I say it's not a disease per se, but serious presentation, we have to describe the sustainable measures. We also describe the management. Okay, so before we go to, we dive into an upper GI bleed, GIT bleeding or gastrointestinal bleeding is normally divided into two, an upper GI bleed or a lower GI bleed. And what we normally use, the anatomical cutoff, is what we call the ligament of Treitz or suspensory muscle of the duodenum. So any source of bleed proximal or above to the ligament of Treitz is what we refer to as an upper GI bleed. And any source of bleed distal or below to the ligament of Treitz is what we call a lower GI bleed. The occurrence of upper GI bleed is higher, so 70 to 80% of GI hemorrhages are normally attributed to upper GI bleed, and roughly 30% is a lower GI bleed. So I'll just bore you with a bit of statistics here, but the rest is going to be interesting. So about 70%, 75% of patients presenting to the emergency room with GI bleed have an upper source, and upper GI bleed is 5 times more common than lower GI bleed. Patients on antiplatelet therapy have 2-fold increase in bleeding as compared to normal ones. Even patients who have recurrent bleeding, 20% of they have a moderate to high risk, and they normally have a poor prognosis. Yes, Dr. Sorry?
We can't see the presentation. You're not sharing.
Oh, what happened?
Najma,
Yes.
your presentation was okay. You've stopped sharing.
Jamal said he can't see.
Oh, I don't know. I think it's a problem on his end.
Ah, okay. Jamal, are you able to see now?
No,
Okay.
right now you're not sharing anything. You're currently not sharing.
Okay. Now it's okay?
Yes, yes, perfect.
Okay, so, so we have a mortality rate of up to 10% for severe upper GI bleed. So that's why it's very important we know how to, check management of an upper GI bleed, or rather any GI bleed. So the etiology or the causes, we have a lot of literatures. So some of the books divide it into a variceal bleed versus a non-variceal bleed. Some divide it into local or general, and I will take you both through. So let me start with the local causes. So local causes is anything, as we mentioned, upper GI bleed is any source of bleed above or, proximal to the ligament of Treitz. So just think of all the organs that are above the ligament of Treitz. Let's start with the duodenum. So the duodenum, you could have duodenal ulcer, you can have duodenitis. Let's go to the stomach. You can have a gastric ulcer, you can have erosive gastritis, you can have gastric cancers. Let's go to the esophagus. The esophagus, you can have let's start with the one that I just presented right now. An esophageal varices will be a cause of an upper GI bleed there. We have esophagitis, inflammation of the esophagus. You can have erosive esophagitis. You can have a mallory-Weiss tear or mallory-Weiss syndrome, which is a longitudinal tear of the distal third of the esophagus, mainly due to retching and vomiting, and it's mainly associated when people binge drink, alcoholics. Yeah, so that is for even esophageal cancer. So that's how you can approach. That's the local causes. The general causes, you can have hemophilia, hemophilic patients. You can have leukemia. You can have thrombocytopenia. So you can approach it in that way. But for my presentation, I divided them into non-variceal and variceal. So non-variceal is anything not related to vascular causes. And variceal is because of the dilatation or engorgement of the vessels. So for the non-variceal, you can have peptic ulcer disease, which can either be gastric ulcer or a duodenal ulcer. And this is the main, like 50% of upper GI bleed is a result of peptic ulcer disease. Keep that in mind. You can have mucosal erosive diseases, as I mentioned. You can have erosive gastritis or erosive, esophagitis. You can have mallory-Weiss tear. You can have malignancy in any of those two, the gastric CS or the esophageal CS. You can have miscellaneous causes, duofoil lesion. This is it's a very rare. Even GAVE is gastric antral vascular ectasia and angiodysplasia. All these are rare causes of upper GI bleed, but they are there as well. And the variceal bleeds causes of upper GI bleed are only mainly two. You can have esophageal varices or you can have gastric varices. So esophageal varices is subepithelial or submucosal dilatation of the vessels of the mucosa. So yeah, that is the causes of an upper GI bleed. You can approach that. I have here a diagrammatic presentation. The drugs, NSAIDs, and alcohol, those are risk factors. And once the mucosa has been breached or it has been insulted, you can have this all arising. So you can have the 50% I mentioned here, it's here. The PUD, the peptic ulcer disease, gastric ulcer, and duodenal ulcer will cause the majority of the upper GI bleed. You can have hemorrhagic gastropathy and erosions, which can they present like 15 to 20%. You can have varices, either esophageal or gastric. You can have mallory-Weiss syndrome. You can have reflex esophagitis. So at your own time, you can go through this, but I think I made it so clear. So how does upper GI bleed present? So the main symptoms that an upper GI bleed can present is with hematemesis. Hematemesis is vomiting of blood in layman language. So it can either be a fresh and red blood, or it can be digested and digested blood. You can have a coffee ground vomiting or coffee ground vomiters. This is vomiting of there's a bit of blood clot in the vomiters. You can have hematophysia. Hematophysia is passage of bright red blood per rectum. And if you see an upper GI bleed, someone is presenting with an upper GI bleed, and then there's hematophysia, know that the hemorrhage is massive and severe, so you should take an immediate action. You can have melena as well. Melena is passage of loose black tarry stool with the characteristics of foul smell. It has normally an offensive smell. Because of the bleed, the people present with symptoms of anemia. As I brought out in my history, they will have headache, dizziness, easy fatigability, palpitations. They will have syncope sometimes, or loss of consciousness. Yeah, so you have to picture that one as well. They will have symptoms of hemodynamic instability. They'll have tachycardia and all this because they're in shock, hypotension. Associated symptoms of underlying disease. If the cause here is, for example, a coagulopathy issue, they will have petechiae, symptoms of petechiae, purpura, gum bleeding, epistaxis. So you have to also probe in further and get the whole picture. So how do you get to know that this is an upper GI bleed? Even before you do investigation or diagnostic workup, just taking a proper history and doing a thorough examination can give you an idea of what you're dealing with. And then after that, you can go and do the diagnostic workup. So what are you looking for in the history or physical or the examination? You look for signs of hemodynamic instability. The patient could have cold peripheries. They could have high heart rate, low BP, increased thirst, reduced urinary output. Check for signs of stigmata of coagulopathy, skin or gum bleeding or papilla or petechiae, as I mentioned. Even stigmata of underlying disease. For example, if a patient, the cause of the upper GI bleed is maybe a duodenal ulcer or a gastric ulcer, they'll have epigastric pain with burning character and all those. Stigmata of chronic liver disease, you can check for spider nevi, ascites, gynecomastia, trophic testicular atrophy, all these peripheral stigmata of chronic liver disease you can check. Then after that, you can do a full investigation. You start with the baselines, you do routine examinations. You can start with full blood count. It will give you an idea of what you're dealing with. Is there any leukocytopenia? Is there anemia? Is there thrombocytopenia? You want to check if the kidney is functioning well. So you check the UECs. If you want to check if the liver is functioning well, you check for the LFTs, you check for ECG, you check for chest X-ray. And you can do a bleeding time. You can do a coagulation profile. So you want to rule out any underlying coagulopathy. Then after that, you can do an endoscopy. You have to do it early to determine the source of and control the bleeding. So both diagnostic and therapeutic intervention. After that, you can do a CT abdomen. If you need more, if the picture is still unclear, you can do more investigation. You can do a CT abdomen, or you can do a mesenteric angiography if the patient is unstable to do any endoscopy. You can also do a capsule endoscopy to check for occult GI bleed. So now that we have seen the whole picture, I've taken you all through from definition of an upper GI bleed to the causes, the etiology, to the clinical presentation, to the diagnostic workup. Now that you have seen you are dealing with an upper GI bleed, what do you do next? So if the patient is unstable, or you have to do a resuscitative measure. You have to fix 2 large bore IV because you want to monitor you want to maintain and monitor the circulation. And you can also give him or her hemodynamic support. You give fluid and blood. After that, after you have resuscitated the patient, you can give an IV PPI or PPI infusion. So the function of first we start with an 80 milligram as start, and then after that you can have a 40 milligram BD as a maintenance dose. So why do we give an IV, a PPI for a patient with an upper GI bleed? It's for 2 reasons. One is first we want to suppress the acid production. And once you suppress the acid production, you will promote the healing of the gastric mucosa. That's number 1. Number 2, you know that this is a case of bleeding, and we want to stabilize the thrombi that's being formed. So that's another one. It's also used as a hemostasis. So hemostasis and promoting the healing of the gastric mucosa. That's the 2 reasons why we give an IV PPI. Another thing is for the esophageal varices, for the variceal bleed, you give an octreotide. Octreotide is a somatostatin analog, and it's used to reduce, it acts as a vasoconstrictor. So it causes splanchnic vasoconstriction. It causes splanchnic vasoconstriction. And once it does that, there's reduced blood flow to the portal circulation. And once there's reduced blood flow to the portal circulation, we will have reduced intravaricial and portal pressure. You can give antibiotics. Why? Why are you giving antibiotics to a patient with an upper GI bleed? One is because already the gastric mucosa is breached for this patient. So they are at high risk of bacteremia. There's something called spontaneous, it's called spontaneous SBP, spontaneous bacterial peritonitis, SBP. So patients with upper GI bleed are at high risk of infection of the acidic fluid. So what we do is we normally give the first line is IV ceftriaxone. But if you don't have that one, you can give a ciprofloxacin. So you want to prevent any sepsis or bacteremia, even because even sepsis can lead to an urinary tract infections. They can have pneumonia. So you want to prevent all that. So you give them an antibiotic. You want to look for and manage complications such as AKI because of hypovolemia. Because of hypovolemia, they are at risk of getting acute kidney injury. They are at risk of getting encephalopathy because of there is low reserve of the liver. And if there is any coagulopathy that is underlying, so you correct that coagulopathy. And after that, you can do an elective endoscopic evaluation and treatment. So if there is endoscopic, if you want to do an endoscopic therapy, there's two types of endoscopic therapy. You have an urgent and elective. Urgent is less than 12 hours. Elective is within 24 to 48 hours of bleeding. But for statistics show that there's no difference. There's no overall advantage of early endoscopy. That is endoscopy of less than 12 hours in terms of rebleeding, need for surgery or mortality. What are the current endoscopic modalities? Sorry, I'm going to bore you to death, these ones, but it's good. It's good, you know, as we go up, as we become doctors. So the current endoscopic modalities, we have injection therapies. We primarily use dilute adrenaline. You know that adrenaline is a vasoconstrictor. You can have contact thermal therapies. You can have heater probe, mono or bipolar cautery. You can have non-contact thermal methods, argon plasma coagulation. You can have mechanical treatments. You can have combination of the above treatment modalities. What's normally, if you're using an OGD as a therapeutic use, we normally combine two of these of the above modalities. You can combine, for example, an injection therapy with contact thermal therapy, or you can combine a mechanical treatment with an non-contact thermal method like that. That's the preferred method. You combine two of the above modalities. So you can have a second look endoscopy. Like, for example, the first one, you did it 24 hours ago. You can do a second one after the 24 hours. Routine second look endoscopy is not recommended for most patients with peptic ulcer bleeding. However, if there is any persistent stigmata of hemorrhage, you can have a second look endoscopy. And it's normally done 24 hours after the initial endoscopy. So what are the adverse prognostic factors in GI bleed? One is advanced age. Age over 60 is already having a poor prognosis. Shock. SBP of 100, systolic of 100 or less than 100, or peripheral pulse of more than 100. If there is severe coagulopathy, that's like they have an underlying severe coagulopathy. If they're having comorbid medical illness, such as hepatic failure or renal failure, if there's continued or recurrent bleeding, if there's severe active bleeding, such as if there's symptoms or signs of hypotension, multiple transfusion, there's bright red, nasogastric aspirate, all this will give you an idea of if there's a severe active bleeding. Endoscopically, you have identified there is an arterial bleed. Endoscopically, you have identified arterial bleeding or visible vessel. The ulcer location will also be a prognostic factor. Emergency surgery if surgical complication. So what are the take-home message? These ones that I've been blabbering about, maybe they'll burn you to death, but this is the main points you can pick from whatever presentation, whatever I've been presenting so far. So if you see a patient with an upper GI bleed, first thing is early resuscitation. It's very important. Time is of essence. So early resuscitation is very important. Number two, use an high-dose PPI therapy for at least 72 hours for peptic ulcerated bleeding. So don't forget the use of high-dose PPI. As I mentioned, the start dose is 80, but you can gradually reduce to 40 milligram BD. Urgent endoscopic therapy for moderate to severe upper GI bleeding. You can do combination therapy preferred along with medical management. You can consider other interventions. You can have other interventions if endoscopy fails. For example, there's targeted RBC scans and all this. You can check them on your own. Relook the endoscopy as necessary. Remember, I told you
the previous slide, there was a second look endoscopy. You can have that one as well. Treat for specific underlying cause of disease. If there is any underlying coagulopathy, treat that underlying coagulopathy. If there's any underlying PUD, treat that underlying PUD. Thank you. I think I'm done with my presentation.
Thank you very much, Najma. Any question on her presentation? I think the presentation was exhaustive, and upper GI bleed is generally quite straightforward, and but a common presentation in the wards, and all of you must be conversant with it. And maybe a few things to highlight. I don't have a presentation, but emphasize on what Najma mentioned, that in upper GI bleed, largely it's clinical. Your history and physical examination are the most important things. Okay, so essential that you take a good history, physical examination, and then the investigations are largely to support your management. So in your history, you should have the presentation quite clearly probed. What's the bleeding manifestation? Did the patient present with hematophysia? Did the patient present with hematemesis? Did the patient present with melena? Or did he present with combination? So she mentioned that hematophysia is a common presentation of lower GI bleed, but you can have hematophysia as presentation of massive GI bleed. You can have melena stool as the only presentation without hematemesis. So you need to define what's the bleeding manifestation. And then in your history, you need to have severity of the bleeding. So I think that she attempted to give us what's the severity of the bleeding, the blood loss of the patients are. So things like, is the patient syncopal? Is there orthostatic dizziness? Is the patient having easy fatigability, cold extremities? That gives you an idea of the blood loss, okay? And in a history, you need to identify potential source and etiology of the bleed, okay? So giving us the initial presentation of hematemesis already gives us a picture that we're dealing with an upper GI bleed. So that's the potential sources above the ligament of Chris. And then now the rest of the history will try to find the etiology of that. And she broke it down. So in your history, you can have your mind look at things that can affect the esophagus, stomach, and then the duodenum, okay? Then past medical history is important. Was this patient being followed for chronic liver disease? Did he had, like she gave us the history of upper GI bleed before with history of endoscopic therapy? What's the medication history of this patient? Recent NSAID use? Is the patient on anticoagulants? Is the patient on antiplatelets? And if the patient had odynophagia and GI bleed and you're thinking esophagitis, was the patient on oral bisphosphonate or piloesophagitis, okay? Your history also needs to have the complications, because some of the complications that patients with upper GI bleed, especially variceal bleed, can have is they can get hepatic encephalopathy as a complication, because it's a trigger of hepatic, upper GI bleed is a trigger of hepatic encephalopathy, heart failure, renal failure, infections like SPP. So you need to tell us in the history, it must come out that you're trying to probe for the complications of this upper GI bleed. And then importance is comorbidities. Okay, does the patient have heart failure, ischemic heart disease, chronic liver disease, chronic renal disease? All those will be important in terms of your approach to the management. Okay. Once you have a good history physical examination, the next important thing that probably wasn't mentioned in the presentation is risk stratification. Okay, so does everyone who comes with upper GI bleed get admitted? Do they all go to the ward? Are there patients with upper GI bleed who will be managed as an outpatient, and who are those ones? Anyone? Najma, Jamal?
Yes, Doc.
So does everyone who have upper GI bleed go to the ward? Are there patients who are managed as an outpatient?
I think there's a criteria, there's a score they use to evaluate who needs to be admitted and who not. I think they're considering things around urea nitrogen levels, how much of the HB, how low is the HB? Does the patient have any other risk? How is the hemodynamic stability, systolic blood pressures? How is the heart rate? Do they have any symptoms of cardiac or hepatic disease? I think there's a score called Blatchford score, I think they use for the admission. So yes.
Okay, thank you. So that's the point. So risk stratification. Carry on, Jamal.
I think anyone who scores, I'm not very sure, more than two. I think the ones who hospitalized. I'm not sure, but I know there's that
So more
criteria.
Okay, thank you. So it's important that you have risk stratification, and as he's correctly mentioned, there are some different risk stratification tools that you can use, but I think the easier one is the Blatchford score, and the other scores like Rockall score usually requires you to do endoscopy. So as an outpatient, this patient comes to the casualty and you have upper GI bleed. You want to determine, is this the patient that I want to admit and requires urgent endoscopy? Because the importance of this risk stratification is it determines your risk of mortality, risk of rebleeding, okay, and the urgency of the clinical intervention in terms of endoscopy. Okay, so the more practical one is the Glasgow Blatchford score, and so parameters is your vitals, your BUN, your HB. Does the patient have history of malignant syncope, which is trying to determine your severity, and hepatic and cardiac disease. So again, importance of the comorbidities in the history. Okay, so anyone who scores more than one is usually a patient who requires has a risk of rebleeding and urgent clinical intervention. So it's usually 0 to 1 are the ones that you can possibly consider as an outpatient management. So patient with Blatchford score of 0 to 1 with no significant comorbidities, vital signs are stable, does not live far from where they can access medical care, and have mechanisms for prompt gastro evaluation or OGD to be done within 72 hours. Those are the patients that you can allow home. Okay? So not just the score, and then those other elements, because should you send them home and they can't access the nearest place where they can do OGD is probably 3-4 hours drive, then that patient, even with a score of 0, still requires admission. Okay, so it's important that you have the risk stratification, and I think management was well covered. Although management generally for upper GI bleed, you have management for variceal bleeding and management for non-variceal bleeding. So some of the points that Najma emphasized, some of them are strictly for non-variceal bleeding, and some of them are for variceal bleeding. Okay, but the general principles of management are resuscitation and support, then blood transfusion. So you need to know for the seniors, you need to know who gets transfusion, when do you transfuse, okay? And this patient had pancytopenia. How low was the platelet? When do you transfuse platelets, okay? So generally for patients with upper GI bleed, there's a concept called restrictive blood transfusion strategy. We don't transfuse to a target of high HB, neither so the HB usually when we transfuse, general principle is that when the HB is less than 7. And the exception to that is patients who have active or brisk bleeding, okay? And that largely will also be determined with the hemodynamic parameters of the patient, and the pace of the bleeding, the estimated blood loss. So a rough way of estimating a blood loss in a patient that you find in casualty or in the ward gives you that I have this much bleeding, and you want to have a picture of the extent of the estimated blood loss, is that sometimes when you have mild to moderate blood loss with less than 15% of the blood volume lost, patients will usually have just a resting tachycardia. No orthostasis, no syncope, no pre-syncope, no easy fatigability. So largely what you will find is probably a resting tachycardia. Patients who lose more than 15%, but less than 40% usually have all those symptoms. Now, orthostatic hypotension, dizziness, easy fatigability. So they have more severe symptoms. And patients who have a significant severe blood loss, more than 40%, will actually have supine hypotension. Okay, so all those will determine patients who have brisk bleeding. You don't rely on the HB, they transfuse the patient. Okay. And then the other exception that you have a higher cutoff patient with ischemic heart disease, acute coronary syndrome in upper GI bleed. HB usually we transfuse even if the HB is less than 8. So anything less than 8 we transfuse. So 60 years final, you can be asked about your who do you transfuse and what's the strategy for transfusion. Okay. For platelets, generally, platelets above 50 is fine. Endoscopy, you can do anything above 20,000. Patients who have active bleeding with platelet counts less than 20,000, then we transfuse platelets. Okay. And the other principle is now pharmacologic therapy for bleeding. So what Najma has emphasized, vasoactive agents, talipressine or octreotide for 3 to 5 days for variceal bleeding. Okay. And note that high dose PPI that Najma emphasized are for non-variceal bleeding. There is no role of high dose PPI in variceal bleeding. And those of you who will meet Prof. Ogut in your finals, you have a variceal bleeding, don't make the mistake of talking about IV PPI, except in situations where like this patient has variceal bleeding, but also has portal hypertension gastropathy, has erosive esophagitis without presentation, then probably you're not sure whether you're dealing with purely variceal bleeding or there is also gastropathy underlying. Okay, but technically for all variceal bleeding, there is no benefit in IV PPI. IV PPI is for non-variceal bleeding. Okay, and then was it Faria? Someone asked, what's the role of endoscopy? So your endoscopy is to identify the source of the bleeding. And usually it's supposed to be done immediately after your fluid resuscitation and within 12 hours of admission. Okay. And then the other principle is to prevent and manage complications. Okay. She mentioned correctly, patients need to be on prophylaxis for infection. Those are variceal bleeding. Again, there is no role in non-variceal bleeding. You don't have to have prophylactic antibiotic in non-variceal bleeding. So it's variceal bleeding who are at higher risk of getting spontaneous bacterial peritonitis that you put them on antibiotic prophylaxis. We commonly use cephalosporins, but the first line is usually fluoroquinolones. Okay, areas where there is high resistance of fluoroquinolones is where now you use cephalosporins, and that's why probably you find largely we use cephalosporins in our settings. Again, look for hepatic encephalopathy, prevent, or when they occur, manage. Look for renal failure because of your massive blood loss and or hepatorenal syndrome, prevent, manage when they occur. Okay. And the long-term management is to prevent rebleeding, especially in our case where we're having variceal bleeding. And these patients need to be on long-term non-selective beta blockers. And that was why it was important in the history that this patient has had previous history of GI bleed with endoscopic therapy. Was he on non-selective beta blockers to prevent the risk of rebleeding? If he was he compliant to this? Okay. And then the importance of surveillance endoscopy. And then what happens in case patients don't respond to? Every patient who has had variceal bleeding needs to have endoscopic therapy. Najma emphasized, gave you possible modalities that can be used, but what is usually commonly used is ligation and sclerotherapy. So patient on ligation who has had ligation and non-selective beta blocker who are still refractory, then you have measures such as TIPS or transplantation in some of the patients. What happens if Najma, I think in your last slides you had patients who have OGD done, OGD is negative. What next? Patient with this patient presented with melena stool, endoscopy was done, or maybe not Najma, any of the 60 years, and OGD is negative. You can't find a lesion.
I think I mentioned the interventional radiology, the tagged RBC scan.
Is that the first thing you go to? So usually after endoscopy, it's colonoscopy. Okay.
Okay.
Okay. Because melena,
Yes.
for example, might be both upper GI and lower GI bleed. Okay. Then if colonoscopy is negative, that's when you evaluate for small bowel bleed. Okay. So your capsule endoscopy, your CT angios will come in as an evaluation for small bowel bleed. Okay. Or if the patient is having massive bleeding, unstable, or GD is negative, then you skip colonoscopy and you now do your CT angio because you want to do an intervention. You'll do a CT angio, and if you find the bleed, you can have interventional radiology doing embolization of the bleeding vessel. Okay. But generally, stable patients, when you do OGD, if it's negative, it's colonoscopy. If it's negative, then we do small bowel bleed evaluation. Okay. Occult bleed. Okay. So in a nutshell, I think that's what I wanted to say. Initial part for the history is in terms of the clerkship and clinical evaluation of the patient, what must be in your history, and then the principles of management for the senior guys. And upper GI bleed is quite common, easy, but people have high expectation. When you're presenting a patient with upper GI bleed and they go to the management, your principles must be very clear. How do you manage? How do you do the fluid resuscitation? Who do you transfuse? How do you transfuse? Okay. And risk stratification and long-term management. Okay.
Yes, Dr.
Are there any questions? I think there are no further questions. Najma's presentation must have been quite clear.
Jamal is asking, please elaborate how upper GI bleed triggers hepatic encephalopathy.
So upper GI bleed will result is one of the causes of hyperammonemia. Okay. Breakdown product, and therefore predisposes to hepatic encephalopathy. Okay, so it's either you have usually hepatic encephalopathy. The mechanisms are either you have reduced capacity to excrete ammonia, or you have excessive production. So it's one of the things that contributes to excessive production. Okay. So even in your patients that you will find hepatic encephalopathy, you will want to find out have they had recent upper GI bleed.
Yeah, I think that's clear, Dr. Thank you. Someone else is asking, Desmond is asking, if you give high dose PPI, 80 milligrams start, after how long will you start the maintenance dose?
So usually we do a high dose 80, and then patients are actually kept on infusion 8 milligram per hour. Okay.
Okay.
So you keep them on maintenance, and then once you do an endoscopy, there are patients who usually have stigmatas of bleeding that I think you mentioned at the end. So patients who have stigmatas of bleeding after endoscopy, you again keep them on high dose PPIs for at least 3 to 5 days.
Okay. Thank you. That's quite clear. Someone is asking, how does dexamethasone bring about stress ulcers in newborn?
So I think that will be for the pediatricians, but generally I think okay. So all steroids, not just dexamethasone, steroids will give you ulcers, and I think because of the stories about prostaglandin. Okay, so it's the effect on prostaglandin production. But I think it's not just for the newborns. Generally, all patients that you're going to put on steroids, especially for long term, they're at risk of steroid-induced gastritis.
Okay, someone is asking what could explain the jaundice in this presentation.
That's not Najma who is talking.
Yes, what could explain the jaundice in the presentation? Yeah, I reported there was history of yellowness of eyes.
What do you think?
Yeah, I'm not sure, but
who are the 6 years in the group? This patient we still don't know what's the cause of his portal hypertension. But from Najma's presentation, what are the more likely things? patient has splenomegaly
Yes.
and liver span was normal. Right?
Liver span small. Yes.
Okay. So what are the possible causes of
I think increased sequestration of the red blood cells in the spleen, increased hemolysis, in short.
Okay, so that's one possibility. What else? Jaundice can also be because of liver disease, although with a normal liver span, then with such significant features of portal hypertension, the more likely things are usually either pre-hepatic, more often pre-hepatic, or hepatic. Hepatic largely will be things like schistosomiasis. Okay.
Okay.
So when you're looking at differentials of what can give you portal hypertension, you have a patient with portal hypertension, the size of your liver is very important. Okay. Although you can have, even with early cirrhosis or macronodular cirrhosis, you can still have a large or normal liver. But when you find a normal liver or an enlarged liver with such a significant splenomegaly, then possibly what we're having are pre-hepatic causes of portal hypertension.
Okay, thank you. I think there's no more other question. Jamal, I think we are done with the presentation. Is there any remarks you want to give?
Thank you so much, Najma, for the wonderful presentation. You've done quite a good job in preparing, clerking, and presenting. So thank you so much. Many people appreciating you, and also Daktari, we can really not thank you enough for making time from your busy schedule. I know you have another meeting to go into after this, and you've really found time to actually come and guide us through the topic. We really thank you so much. We've learned a lot today, and also for the members for tuning in and participating. Thank you so much. Have a good night. See you next time.